I decided to divide the diabetes PowerPoint into 3 different sections because I'm having a hard time uploading them as videos, and maybe it will be better for you to be able to view them. So this next section is going to talk about care of the diabetic client. So we'll talk about nutrition, glucose monitoring, activity, exercise, and drug therapy. So there's quite a bit in here, quite a bit of material. So you have a table with the different types of insulin, onset, peak, duration, posted on Blackboard. I mentioned it's on your quiz, so I do want to just clarify any questions about the different types of insulin. Make sure you jot down questions that you have so that we can go over it. You're going to need to really know how to safely time your administration of different types of insulin, when to monitor your client for hypoglycemia, which the highest risk for hypoglycemia would be the peak of that insulin, so when it has its maximum effect. You're going to want to know the duration of insulin. So your bolus insulin or mealtime insulin or insulin that's going to quickly bring down a blood sugar is going to be your rapid or short-acting insulin. So I'm sure a lot of you have been administering Aspart or Lispro insulin. You really want to time that approximately 15 minutes before meals. That's going to have a rapid onset, so 10 to 30 minute onset. You always want to be cautious. The short-acting insulin, you have a little bit longer, so you'd want to time that regular insulin like 30 minutes before a meal. There's only one short-acting insulin, so that's easy to remember. The only IV insulin is regular insulin. So when we talk about IV push insulin and an acute hyperglycemic complication, it's always going to be regular insulin. If you're talking about an insulin drip in ICU, regular insulin. So the basal or background insulin, remember we normally have a steady continuous amount and small amounts in the background when you have a normal functioning pancreas. That's going to be your intermediate or your long-acting. Intermediate is always going to be twice-a-day dosing because look at that duration. It's closer to the 12-hour. So it might be, morning and bedtime, morning and dinner, depending on timing. But it's usually going to be twice-a-day dosing, and that's due to the duration. The long-acting is a 24-hour duration. There's really no peak. So that is a steady background insulin. There's the lowest risk for hypoglycemia with the long-acting insulin because it really does not have a peak. You may see clients that have severe insulin resistance and need high amounts of insulin for glucose management on, some different dosing, but in general it's once a day, and it doesn't matter if it's in the morning or in the evening as long as it's the same time every day. You would never mix long-acting insulin. You can certainly mix your rapid and short with intermediate in the same syringe, and that way your client only has to receive one injection. The inhaled insulin is really new, out the past few years. It's not used a lot. It's pretty expensive. It's contraindicated in clients that have asthma, COPD. So that's not something that you're really going to see a lot of. That's not going to be on your test right now, but I just wanted to mention that. So basal bolus, super important to remember. I would make flashcards for your insulin, and I would be able to divide which ones are basal, which ones are bolus. You're going to need to know that. So again, bolus is your rapid or short. That's going to be multiple day dosing. So for example, maybe 3 times a day before meals. Your basal is that background insulin. That's going to be your intermediate or your long acting. So you'll see a higher dose on the basal insulin because it has a long duration. And depending on if it's intermediate or long acting, it may be once a day, it may be twice a day. So definitely have a good understanding of those. So your combination insulin, that would be mixing a short or rapid, so one of our bolus insulins, with intermediate insulin. That would be in the same syringe. Remember, you draw up clear to cloudy. If you want to star this on the side of the slide, it's very important to realize that this combination insulin you would never give in the middle of the day. It's always going to be morning and night because it has that intermediate in there. It has a 12-hour or more duration. So you're not going to want to give it in the middle of the day and have it peak at an unusual time during the night when the client is sleeping. So it's always going to be morning and night. It's going to have, let's say, short-acting insulin and intermediate in the same syringe. So the client gets one injection, but it provides meal coverage and that background insulin. There are pre-mixed insulins that come in a vial, and it's called 70/30 or 75/25. The higher number, that 70%, would be the intermediate. So it's a percentage, so it would be 70% intermediate insulin, and the smaller number would be the short-acting insulin, whatever the bolus is that is mixed in that vial. You do have to take into consideration, is a client able to mix their own insulin? Do they have severe arthritis? Do they have any problems with their vision? When I spent time with public health, we would go in once a week and we would draw up insulin for a client for the week. Her mixed insulin, she could self-inject, she could check her own blood sugar, she had a talking meter, but she couldn't see to draw up her own insulin. So insulin should be stored in the refrigerator until it's open, and then it's good for 30 days at room temperature. Everyone's familiar with the location to give a subcutaneous injection. I just want to remind you to wait that 30 seconds or so after you inject the insulin. A lot of times I'm in clinical with students and they're quickly giving that injection and removing the needle, but you do want to wait the few seconds after just to make sure the insulin is administered. So you should rotate sites in one anatomical location for a week. The reason for that is different anatomical locations have different rates of absorption. So you might get different glucose management. So it's best for a week to use one site, but different spots on that anatomical location. So for example, you would not want to give your morning insulin in the arm, your afternoon insulin in the abdomen, and your dinner insulin in the thigh. You would just choose the thigh for a week and rotate sites on the thigh. Insulin is always sub-Q or IV. We talked about regular insulin being the insulin administered IV. The fastest absorption is the abdomen, but you can certainly use all different sites. You don't want to inject into a muscle that's going to be exercised shortly, because that could speed up absorption. just a quick reminder, the anatomical locations for sub-Q injection for insulin. So if you haven't given insulin this semester in clinical, think back to your 100 days and how tiny those little insulin syringes are. You always want to choose the smallest syringe for your dose. So if you're working with pediatric clients, they have 0.3 ml syringes. For adults, it's pretty standard, the 0.5 ml or 1 ml. So if we were giving 5 units of aspart, we would want to use that half a ml syringe. And then there's just some other tips here on selection and administration that should be a review. So as a nurse, just remember, never recap a syringe after you've given an injection. Familiarize yourself with the safety. There's a safety device on every syringe now that we use in the clinical setting. At home, clients do not need to use alcohol, just washing with soap and water. In the hospital setting, skilled nursing facility setting, you would still use alcohol because of the increased risk of infection. There are insulin pens, which are wonderful. I'll show you on the next slide. So these are pens that are filled with insulin. The client can just dial to the amount of units that they need to administer. They change their needle with each injection. It just screws on the end, and then it's just like a syringe, and they could administer their insulin. It's great for travel. You don't need supplies, needles, vials of insulin. So they're very convenient. You keep them in the refrigerator until they're opened, and then again, they're good for 30 days. The only downside is they're expensive. Some insurance companies don't cover them, or the copay is extremely high. So not everyone is able to take advantage of how convenient they are. But all different insulin brands, Glargine, Aspart, they do sell pens. So I want to highlight some important pieces of information on insulin pump therapy. So first I want to mention that insulin pumps are primarily used in our type 1 diabetic, but they can be used in a type 2 that has severe insulin resistance and increased insulin requirements, depending on the patient. But most of the time they're for your type 1. There's all different insulin pumps, and as a staff RN, you would not be responsible for knowing how to work all these different pumps. If you were a diabetic educator, you would be more familiar and have more training. But the patient receives quite a bit of training and is really the expert. So if you are working in acute care and you have a client come in with an insulin pump, they really are the expert. So if they're alert and oriented and able to manage their own pump, most facilities will have the client leave the pump on, and as the nurse, you're still responsible to know what is their basal rate, how much are they bolusing themselves, what is their blood glucose. But because insulin pump therapy really provides the best glucose control, that is usually the policy in most facilities. So again, I just want to mention some really important key points if you want to just star these and jot some notes on your PowerPoint. There is a cannula catheter that is inserted under the skin that needs to be changed every 2 to 3 days, and that's going to decrease the risk of site infection. And it can be any site that you can normally inject insulin. So if you want to flip back a couple slides to see different sites that you could insert that. The client inserts it themselves. The actual pump, the physician would give the client a program. So maybe they are on 0.2 units per hour of insulin, And then at mealtime, maybe they bolus themselves with 1 unit for every 10 grams of carbs ingested. So if they had a 60-gram carb meal, they would bolus themselves with 6 units. Patients on insulin pump therapy, a lot of times they have a continuous glucose monitor. Some of the CGMs communicate with the pumps, some do not. If a client did not have a CGM, a continuous glucose monitor, they would be checking their blood sugar very frequently, so 4 to 8 times per day on insulin pump therapy. It's important to know the type of insulin in an insulin pump. It's always going to be rapid insulin. This is the only time that the insulin pump with rapid insulin, the rapid insulin acts as both the basal and the bolus. Because it is continuously infusing 24 hours a day at a slow rate, it is acting as a basal insulin, and then the client is bolusing themselves with increased amounts at meal times, and that is the bolus. And it's the same rapid insulin in that pump. Now the client would have to fill the pump with insulin. They would have to be able to do the math calculations, program the pump, change their site every 2 to 3 days. So these patients do need to be, alert and oriented and really on top of things. You actually need more training to have an insulin pump versus doing insulin injections. And clients, a lot of students think it's easier, but it's more complicated. So you want to make sure that somebody has the cognitive ability, that they have the understanding of their plan, and that they're able to manipulate the pump. So any client that really had difficulty with dexterity or any cognitive issues, that might be a problem. So if you have a client that's newly diagnosed with diabetes, type 1 diabetes, pretty shortly, if they're a good candidate and the insurance covers it, they're going to want to try to get that client on a pump as soon as possible, because clients on pump therapy have better glucose control and decreased risk of complications. There are some other concerns with insulin pump therapy, so just something to be aware of. We talked about changing the site every 2 to 3 days. That's due to the risk of infection. I had a student actually a year or so ago that was a type 1 diabetic on an insulin pump, and she had a GI bug and was really sick, nausea, vomiting, just tired. Her insulin pump catheter became dislodged in the middle of the night. She slept for another 6 or 7 hours, didn't realize it. She was not getting her basal insulin and woke up and was in an early DKA. So that is a complication, is pump malfunction or the catheter becoming dislodged. So there is a risk for DKA. You do have to be able to afford and have insurance coverage for the pump, the insulin, the catheter, the tubing, the glucose monitor. There's a lot of cost associated with this. You are attached to a device 24 hours a day. So that's another concern that some individuals might have, but there's lots of people that have insulin pumps, and again, it really prevents a lot of these complications, so it's a great choice for some clients. So insulin therapy in general, complications, hypoglycemia, which we'll talk about with our acute complications, an allergic reaction. So that's pretty rare to have a local reaction. It would be usually a local reaction and sometimes a a different type of insulin in the same class, so a different type of rapid insulin, the client might not have that local reaction. A true allergy is really quite rare, and it could be a reaction to the rubber in the vial or a preservative. Lipodystrophy is the loss of fatty tissue. So again, the importance of rotating injections with both of these, and hypertrophy is thickening of the subcutaneous tissue from that repeated injecting, and that can cause discomfort, it can impair insulin absorption, so again, just good patient teaching. All right, these next two are super important. They will definitely be on your exam. Samoji effect and dawn phenomenon. And I'll go over both of these. And again, if you have questions, jot them down, email me. So first we'll talk about Samoji effect. These clients become hypoglycemic in the middle of the night. So between 2 a.m. and 4 a.m., their blood sugar drops, their counter-regulatory hormones kick into action, and when the patient wakes up in the morning, they are hyperglycemic. If you didn't know about that hypoglycemic episode in the middle of the night, you might think that they need more insulin, but actually with Samoji effect, you need to prevent the blood glucose from dropping in the middle of the night, so they need a bedtime snack or they need decreased insulin at bedtime to prevent that. So I remember the O's in Samoji, and the blood sugar is low with the big O, and they actually need less insulin or a bedtime snack to prevent that. So when you're looking at dawn phenomenon, these patients also wake up in the morning and they are hyperglycemic. So the morning is the same. But what's happening with dawn phenomenon, they actually have increased production of counter-regulatory hormones, and they are hyperglycemic. So they have increased growth hormone cortisol that's causing their hyperglycemia, and they actually do need more insulin. So two very different things going on and different treatments. So in order to evaluate for these, you really need to check that blood sugar in the middle of the night. So anyone that works 11 to 7 shift in acute care, you may be asked to do 2 a.m. blood glucose checks. Clients may not be happy with you that you're waking them up in the middle of the night to check their blood sugar, but it's to evaluate for this. Without knowing what that actual blood sugar is, you really don't know what's going on and you don't know how to treat them. A patient at home. It's not uncommon for a physician to say, for 1 week, I want you to set your alarm on your cell phone, wake up at 3 a.m., 2 a.m., check your blood sugar, and keep a record, and then send me the results so that they can evaluate what's going on when they're really trying to manage the client's blood glucose. Okay, so moving on to the oral agents and the non-insulin injectables. These are really going to be for our type 2 diabetics that have some insulin production. So you can use these in combination, the oral agents in combination with non-insulin injectables, or oral agents in combination with insulin. It really depends on the client's insulin needs based on their glucose control. So this is kind of a nice slide. This is right out of your textbook. It shows the major classes of oral agents and where they're working, how their mechanism of action. So this might be something that would be helpful for you to take a look at, and we're going to go through the most common drug classes that I really want you to know on the next couple slides. So you absolutely have to know the biguanides. That's one of the most common classes of oral agents. There's really only one medication in this class, metformin. Perhaps you've administered this in clinical. Again, extremely common. It may be used actually in a pre-diabetic to help promote weight loss and prevent the onset of type 2 diabetes, but it's also commonly used in type 2 diabetes. It does reduce glucose production by the liver. It improves insulin sensitivity. Like I mentioned, it induces weight loss. So it's a really has great effects. It does not increase insulin production. That's important to know. There's also a few nursing considerations for patient teaching to prevent complications. So you do want to try to encourage your client to take it with food. It can cause some GI upset, diarrhea. That usually improves once the client's been on it for a period of time. You do want to caution any use of alcohol and be cautious in any client that has any cardiac kidney disease. The other big thing I want to mention, if you want to start this, is if a client is going to have an outpatient procedure with the use of IV contrast, clients are at risk for acute kidney injury. So you would want to look at their GFR, and if they had a GFR less than 30, you would have a protocol in place that the client would hold the medication 48 hours prior. Renal function would be assessed after the exam using the dye, and then the client would resume the medication 48 hours after. So sometimes things are emergent. Somebody goes into the emergency room, they're having severe abdominal pain, they need to have a CAT scan of the abdomen with oral and IV contrast. In that case, the patient, they would look at the risks versus the benefits, the patient's renal function. They might hydrate them with IV fluids, closely monitor their renal function after. But best case, if they were having a scheduled exam, that would be something as the nurse that you'd want to thoroughly assess. So you see your client's diabetic, they're on metformin, you know that they're going to have this procedure using IV dye. Let's further assess their renal function and take a look at that. So this next class, another very common, important class to know, the sulfonylureas. If you want to just memorize glipizide or glyburide, those two are the most common. These actually increase insulin production from the pancreas. So they can really have a big impact on glucose control in our type 2 diabetic. They do have a side effect of hypoglycemia, which makes sense based on their action. And if you had a client that was NPO except for medications, this would be a medication that you would really want to question giving and perhaps contact the physician because it is going to actually stimulate insulin production. So I actually encourage you to make flashcards for these classes of oral agents. The meglitinides, the third class that we're covering, again, this is another important class. These also increase insulin production from the pancreas. They have a more rapid onset, so these have multiple time a day dosing, so it might be before each meal. So you want to encourage your client to make sure that they're going to eat a meal within 30 minutes. Timing is important for these. And if they're going to skip a meal, they really should hold the dose. So that would be all important patient teaching if you want to star that. And I would be able to recognize the repaglitinide that is the most common. And it does have a possible side effect of hypoglycemia, again, if the client doesn't eat. So you have the information on the rest of the classes all here on the slides. These alpha-glucosidase inhibitors, they're really starch blockers. The client takes them with the first bite of each meal. It does slow absorption of carbohydrates in the small intestines. Major side effects would be gas, bloating, discomfort. The thiazolinidones, these are not usually prescribed anymore to new diabetic patients, but clients that have been on these for a number of years and it's working well for them, you will still see a lot of patients on the pioglitazone. There are some major side effects with these. They are really called insulin sensitizers, and they do have good effect with clients that suffer from insulin resistance, but they do have some major cardiovascular side effects and can increase the risk of MI. So one of the other drugs in this class was actually taken off the market, but you will still see some clients on the pioglitazone, a lot of your older clients. These next two slides, I'm just going to let you review the information on the slides. The DDP4 inhibitors, they really work to inactivate the incretin hormone, and which results in increased insulin release and decreased glucagon secretion. And then the next one, this is actually a newer class, the SGLT2 inhibitors, and you've probably been seeing commercials on the TV for Invokana, but these actually increase the excretion of glucose in the kidney. So again, a newer class oral agent that you might see. So I know there's a lot of drugs with diabetes. We just went through all of the oral agents. We've covered the sub-Q insulin. The last two classes here are non-insulin injectables, and you're going to be seeing this first class a lot more. This is very attractive to your type 2 diabetic client that does not want to go on insulin, so you may see clients on these non-insulin injectables. So glucagon-like peptide-1 receptor agonists. They increase insulin synthesis, they inhibit the glucagon secretion, they actually slow gastric emptying, so clients feel full sooner and it decreases oral consumption. So it does stimulate weight loss and really is having good results. This can be therapy for clients that are type 2, that are on perhaps several classes of oral agents and not getting good glucose management, and this is an alternative to going on insulin. So one thing that's important to know is that these can be used with oral agents in a type 2 diabetic, but they cannot be used with insulin therapy. The reason that these are more attractive than insulin is some of these extended release, for example, dulaglutide, the Trulicity, that's once a week injection. So if you have a type 2 diabetic that is on oral agent activity, exercise, and really, not crazy about going on insulin, which would be daily multiple dosing injections, if you could convince them to go on a medication where they need one shot a week, and it's going to improve their glucose management, that might be very doable for a client. So these are, again, newer the past few years and really having good effect. You do want to ask clients to take this, take their oral meds 1 hour before injection, because it can alter the absorption of the medication due to the mechanism of action. last class, amylin analogs. The one example would be pramlintide. It is a non-insulin injectable. It does slow gastric emptying. Again, patients have decreased oral consumption. It reduces that postprandial glucagon secretion. This is not used as much. This requires 3-time-a-day dosing before meals. There's a risk of increased risk of hypoglycemia, so it can't be used. It can't be mixed in the same syringe with insulin, but again, this is not as common as the last class that we just talked about, but I just wanted you to know there is another non-insulin injectable. So you also have to be aware of other drugs that your client is on and how they might impact blood glucose. Beta blockers actually block that sympathetic nervous system the symptoms that the client would be experiencing. So that's something to be aware of. A client that's diabetic, that's on a beta blocker, they might not have classic symptoms of hypoglycemia that someone would normally experience, that shakiness, that tachycardia, because they're on a beta blocker. Thiazide and loop diuretics can actually cause hyperglycemia. So just being aware of other drugs that your client is on their med list is important. So we're going to go over some basic nutrition therapy for our diabetic client. If you decide to specialize as a diabetic educator, you would really be working with a team. You would have a physician, a dietitian, and you would be in the role as a nurse educator. The staff RN role is really to provide ongoing nutrition support. So just teaching, not the initial teaching. So a couple things I just want to point out. You do really want to individualize your teaching to the age of your client, to their learning level. You want to take cultural and religious practices into consideration because nutrition food has a big impact on those. I'll just give you one example. I took care of a pediatric client that was a type 1 diabetic, and her family was Italian, and to show concern and love and that they care, they'd bring in tons of pasta dishes and homemade food. Really not the best situation for somebody admitted with DKA in a hyperglycemic state. But so cultural preferences definitely impact diabetes. So carbohydrates, important part of the meal plan. You do want to encourage your client to make good food choices for carbs. I do have some nutrition electronic resources on a variety of different websites that I've uploaded to Blackboard that you can take a look at. So glycemic index, carb counting, there's quite a few different resources on there for you to look at. Encouraging fiber is important for our diabetic client. In general, low fat, because we are concerned about cardiovascular complications. Protein is important. You do want to make sure that you discourage diet trends. So like a high protein diet could be really dangerous for a diabetic. So that would be individualized. So alcohol would be 1 drink a day for women and 2 drinks a day for men. When people think of alcohol, they usually think of carbs and sugar and hyperglycemia. But one thing that I want to point out, and please star this on your slide, that alcohol in excess actually inhibits gluconeogenesis by the liver. So if you have a client that has medications on board that's increasing insulin release, or they're taking subcutaneous insulin, now that the liver is kind of busy dealing with this alcohol and unable to release stored glucose, patients are really at a high risk for hypoglycemia. So it's important to teach your patients that hypoglycemia can certainly be caused by alcohol. So you want to make sure you're eating and making wise choices with the drinks that you're choosing in moderation. So I don't expect you to become an expert in carb counting, but 15 grams is one carb serving. Meals are typically 40 to 60 grams of carbs per meal. If a client is on carb coverage, they're going to have a prescription from their physician that says 1 unit of insulin, of aspart insulin per 10 grams of carbs ingested, or 15 grams of carbs ingested. And that's why it's important to read a food label to know what a carb serving is, to be able to count your carbs if you're on carb coverage. So I just want to go over what to focus on for nutrition, that it's individualized. A dietitian would provide the initial teaching, and the RN role is ongoing support. I would encourage you to take a peek at the resources posted on Blackboard, the nutrition resources. Reading a food label, a lot of clients don't know what a serving size is. Portion control, making good food choices, choosing foods with lower glycemic index, increase fresh fruits, vegetables, fiber, all of those things are important. And then thinking about different ages, so using free online gaming where a pediatric client can click and drag foods and create their own plate, or an adult or a teenager, adolescent, using apps on their phone like Calorie King, which can help, count carbs and be useful for, especially for a diabetic. Also thinking about, like an adolescents want to be like their friends. They want to be like their peers. So they want to be able to go to get fast food or do different activities. So as long as it's in moderation and included in their meal plan, eating out is fine, and just really providing individualized teaching based on your client. So exercise is important. We want to promote weight loss. 30 minutes 5 times a week. It definitely improves insulin resistance, blood glucose control, induces weight loss. It helps with cholesterol, blood pressure. So exercise is a big part of our treatment for diabetes. There is a risk of hypoglycemia when exercising. So you would want, for our type 1 diabetic that's on insulin therapy, you would want to encourage your client to exercise 1 hour after a meal, or have a carb-containing snack prior to exercise. Check their blood glucose before exercise, perhaps in the middle, after. If you have a child that is diabetic and they're playing a game, a soccer game after school, they really need to be able to check their blood sugar, have a snack, make sure their coach is aware, be able to hydrate and check their blood sugar halfway through and after. If a client does strenuous activity, that can really be a stressor to the body. So if your blood glucose is greater than 250, you really would want to hold off on exercising. Blood glucose monitoring, super important. The more somebody checks their blood sugar, the better glucose control they're going to have. When I was first a nurse, clients would keep a log of their blood sugars and bring them in to the physician's office or the hospital, and they could put in different values if they, didn't want their physician to know that they've been running in the 200s. Now with the new glucose monitors over the past several years, they can bring their glucose monitor in and the physician's office can have an electronic transfer of information, so they can get all of that accurate information, or they can even send that information from home. So that's really helpful. So there's all different blood glucose monitors. You can't be an expert with all of them. A lot of times if I have a newly diagnosed diabetic, I fill their prescription, obtain their glucometer that they're going to go home with. I sit down and I read the instructions, and then we go over it together and make sure the client can check their own blood sugar before they go home, because teaching them on the hospital meter really isn't going to be helpful because it's going to be totally different. There's always a help number on the meter, so that's important. As the nurse, I've sat down and called for support on a glucometer, on an insulin pump, but also share that with your patient. So if they're home and they're struggling, they have a support line that they can call. Most of the clients will be pricking their finger, so the side of their finger, to check their blood glucose. There are some alternative blood sampling sites, like on the forearm. That's pretty uncommon. The continuous glucose monitors, the CGMs, are becoming more and more common, and that's just a sensor just underneath the skin, and it reads interstitial glucose every 15 minutes or so. These can be for type 1 or type 2. They are being covered more often now by insurance companies, and some of the insulin pumps will actually communicate with the CGMs. So that's all really exciting. And one thing I do want to point out is that there's been some errors made, because some people have thought that a CGM is actually an insulin pump, because if you don't know if you're not familiar with CGMs and insulin pumps, a lot of them look similar. So really make sure that you know what your patient has, because it may be a CGM and not an insulin pump, but they both look similar. Nursing 102 covers bariatric surgery. It is a treatment for pre-diabetics or type 2 diabetics with complications. It does promote weight loss and improve glucose control. Also, pancreas transplants for type 1 diabetics. A lot of times it's done at the same time as a kidney transplant. I actually cared for a client, and when I was sharing this with my first class, for some reason I actually got teary-eyed, but this was a patient in her 30s, type 1 diabetic, very brittle diabetic, huge fluctuations with her blood sugar. She had hypoglycemic unawareness, which we're going to talk about, but she really didn't get those warnings that her blood sugar was dropping. 3 small children. She was legally blind, had diabetic nephropathy, end-stage renal disease, was on dialysis. She had severe neuropathy, and she would just all of a sudden drop and become hypoglycemic, so she really couldn't be home alone with her children. She always had to have somebody else there, and it really had a huge impact on her life. And she was able to get a kidney transplant, pancreas transplant, no longer be diabetic, no longer be on dialysis, and just a huge change in her life. All of those chronic complications are irreversible, but it's like she has a a new gift of life is how she describes it, and it was really rewarding to take care of her and have her share her story. So we talked a little bit about culture. The diabetes.org website has some great resources, but you really want to individualize your teaching and, again, food preferences. The diabetes.org resource would be great to refer to. So I'm going to have you review the slides, the next few slides here on the nursing process. Really doing that thorough assessment and planning the interventions, the patient teaching, preventing complications, the health promotion, and jot down any questions you have, and we will talk about those questions in our Collaborate session.